Our next speaker is Dr. Lambert, who will talk to us about contact lens correction for aphakia.
So I have no financial interest or relationship to disclose regarding this talk. So this is an area of great interest to me. I've dealt with a lot of children over the years that have aphakia, and so I did some research in preparing this talk about when contact lenses were first used for aphakia, and they go back to the 1950s. Initially, they were using these hard lenses, polymethylmethacrylate lenses. They basically have no oxygen permeability, so in order for the cornea to get oxygen, there has to be an exchange of tears, of oxygen through the tears when the children blink. And the first article I could find that dealt with this was published by a Japanese ophthalmologist, Dr. Saito, in 1959 from Tokyo. And he advocates in this article that children should wear these hard contact lenses continuously, day and night, and actually reports on many patients who in fact did this successfully. And he was quite advanced in terms of his view towards treating cataracts in children. He said, "We think that all types of cataracts in childhood must be operated on as soon as possible, taking care not to allow amblyopia in the squint to occur." And I think at the same time in the United States, there was a lot of reluctance to do cataract surgery on young children, partially because there wasn't clear how you would correct them optically after removing the cataract. And he ends the article by saying that the surgical treatment of cataracts in babies has now become perfect in combination with corneal contact lenses. So these hard contact lenses were used for many years until the soft contact lenses, the hydrogel contact lenses, were approved by the FDA in 1971, and they were approved for daily wear. They have more oxygen permeability than the hard lenses, but still didn't have a great permeability, and so really were not suitable for being worn overnight. The advantage is they're very easy to fit, and they have more initial comfort because when you blink, the contact lens generally stays in place. And that is what usually causes some discomfort. And I did a fellowship in London with David Taylor, and this is the type of contact lens we use to treat aphakic children. They were dispensed by the National Health Service at no cost to the parents. In 1978, the FDA approved gas permeable contact lenses, and they had greater oxygen permeability than the soft lenses. Still wasn't wonderful, so they weren't really recommended to be worn overnight. And the advantage of them is they were available in all powers or parameters. They also were really good at correcting corneal astigmatism, quite durable. But the challenge of these is they're very difficult to fit in a baby. And when I came to Emory in 1988, we had this really outstanding optometrist that in fact could fit babies with these contact lenses. And after him, we had another person, Buddy Russell, who fit these. So I've been kind of spoiled over the years having someone available that can fit these, and they are absolutely wonderful contact lenses. And once parents get used to inserting them, removing them, it's not difficult. In fact, I think it's much easier than a soft contact lens. In 1981, the FDA approved silicone elastomer contact lenses, and they approved them for extended wear for up to 30 days. And the advantage of them is they have a really high oxygen permeability. The disadvantage is that they tend to have mucus stick to them, and so in order to combat this, the company coated them with this plasma that increases the surface wettability, but it wears off after a few months. So generally, these contact lenses have to be replaced about every 3 months. They're also available only in a limited number of parameters, power, diameter, and curvature, and they really don't have the same ability to correct astigmatism, corneal astigmatism, that you have with a gas permeable contact lens. And when I came to Stanford, this is the type of contact lens they were using there, so I had some experience over the last 3 years with these contact lenses. So can we have the first question? So the question is, what kind of contact lens do you primarily use to treat aphakic children in your practice? Silicone elastomer lenses, gas permeable lenses, silicone hydrogel lenses, or none of the above?
And maybe anyone on the panel who works with contact lenses have a suggestion of what they do?
Well, Scott and I worked together for many years, so we're on the same page. We both have the benefit of using somebody who does a great job with rigid gas permeable lenses, so we prefer those.
How about you, Deb?
Deb?
Yeah, we're pretty much all still soft users, very rarely rigid gas permeable lenses.
Anyone
Okay,
else?
looks like it's pretty spread out. Why don't you go on?
Okay, so it looks like this is actually kind of surprising. I would have thought it would have been more skewed towards silicone elastomer lenses, but it was about half used silicone elastomer lenses and about a quarter used gas permeable, a quarter used silicone hydrogel. We did an assessment to look at the literature on contact lens correction aphakia in children. And this was published last year in Ophthalmology. And we essentially asked two questions. The first question was, does the rate of adverse events differ between silicone elastomer and gas permeable contact lenses? We chose just to look at these two type of contact lenses because they were the main type that are used and reported in the literature. Silicone hydrogel lenses were relatively new, and there really wasn't any literature on them. And the second question was, did the visual outcome vary when using these two types of contact lenses in aphakic children? So we identified 161 citations on this topic, reviewed 27 papers, and we assessed 10 of them. None of them had level 1 evidence. There was 4 level 2 evidence and 6 level 3 evidence relevant to this assessment. So the first level 2 evidence was from India, from Asari, published in 1999, and they looked at 74 children who were fit with silicone elastomer contact lenses following cataract surgery. They were a bit older. The median age was 9 months, and they wore them on median duration of 9.5 months. And interestingly, only less than half of the patients had any improvement in their vision with the contact lenses, presumably because they were mostly dealing with older children who had unilateral cataracts, and they were probably densely amblyopic by that time. They had 23 lens-related adverse events, including erosions, sterile ulcers, corneal edema, and what's called a sucked-on lens, where the lens kind of sticks to the eye, very difficult to remove. 2 eyes developed bacterial keratitis. In both cases, the corneal scars were not visually significant. The second level 2 article was from Turkey, from Özbek, published in 2002. They looked at 51 children who were fit with silicone elastomer contact lenses following cataract surgery. They were even older. Their mean age was 19 months. They were followed on a mean of 4.5 years. And at the end of this time period, nearly 90% of the patients were still wearing these contact lenses. So really excellent adherence. And in their series, the vision improved in 70% of the eyes, and they had very few complications, 4 cases of conjunctival irritation and 1 sterile ulcer. And then there's 2 papers, 2 other level 2 evidence papers from the infant aphakia treatment study. Buddy Russell was the lead author on these papers. There's 57 infants randomized to aphakia and contact lens correction in this clinical trial. Their median age at the time of cataract surgery was 1.8 months. And at 12 months, 42 of them were wearing silicone elastomer lenses, 12 were wearing gas permeable lenses, and 3 had worn both. By 5 years, there was fewer children wearing the silicone elastomer lenses, had dropped to 24, and there was more children who were using both, 17. And again, there really were not very many complications. They were all in the silicone elastomer group, except for one in which a gas permeable lens somehow broke when it was on a child's cornea. This shows the visual outcomes in one of these papers. Turns out the median visual acuity was better with the silicone elastomer lenses, but it was not significant. The number of children who wore the rigid gas permeable lenses was very small, and so it's really not comparable. There's 6 level 3 studies we evaluated. They're from France, Netherlands, and the US. 4 of them involved silicone elastomer lenses, 2 wearing 2 gas permeable lenses. They only reported visual outcomes in 2 series. Again, they reported more adverse events with silicone elastomer lenses. So the conclusion of our OTA was that the visual outcomes were similar with silicone elastomer and gas permeable lenses. There's really no RCT that addressed this question specifically. There were more adverse events with the silicone elastomer lenses, probably because they're worn on an extended wear basis rather than the fact there's something wrong with the lenses versus daily wear lenses for the gas peromal lenses. And there really weren't any adverse events that resulted in any type of lasting visual loss from corneal scarring. So we also talked about future research, and certainly there's a lot of interest in silicone hydrogel contact lenses. I was in Ireland a couple of years ago, and this is really the only type of contact lens they use now to treat children. They're actually using them on an extended wear basis, similar to what we do with the silicone elastomer contact lenses in the United States. So the silicone hydrogel lenses have very high decay, and they don't have the deposits forming on them like you have with the silicone elastomer lenses. And we also identified that there's a need for greater parental education, perhaps teaching modules that would help parents know how to manage these contact lenses. So can we have the